Welcome to Unscripted, the AMCP podcast, a look inside managed care pharmacy.
This episode of Unscripted, the AMCP podcast, is sponsored by AbbVie. AbbVie, we find answers that make life better for patients and our world. When does switching therapies make sense? And when does it cause more problems than it solves? In chronic lymphocytic leukemia and small lymphocytic lymphoma, that question matters more than ever. Today, we're digging into the real-world motivations behind non-medical switching and BTK inhibitor therapy, the clinical risks of disrupting effective treatment, and why patients' voice needs to be at the center of these decisions. We'll also talk about a tool that's often overlooked, dose modification, and how it can help patients stay on therapy rather than switch prematurely. Joining me today is Timothy Monk, Manager, Clinical Utilization Intelligence at Kaiser Permanente, and a board-certified oncology pharmacist. Welcome, Timmy.
Well, first, thank you so much for the introduction, Ryan. I'm always grateful to be invited to talk about one of my favorite topics, CLL. I'll start by introducing the disease a little bit. So CLL and SLL are essentially the same disease. They grow very slowly, either in the bloodstream, and that's what we call CLL. And then if it's in the lymph nodes, we call that SLL. These are often very treatable, and most times they're asymptomatic until the patient comes in with what we call B symptoms. You have fever, fatigue, weight loss, and then they are then diagnosed with either CLL or SLL.
Timmy, thanks for that great background. As we think about medical switching and non-medical switching, why is it so important to consider non-medical switching for CLL and SLL when we're thinking about the broader context of both payers and providers? And why is it such an important topic for us to discuss today?
Yeah, medical switching is what we're used to in oncology, and non-medical switching is something that we see in CLL that probably happens more in our space here. And that's because of three primary reasons. One of them is drug interactions, and more so the patient preference within these drug interactions. We used to have this medication that are in capsule formulation, and when that happened, people did not want to take their CLL medications 2 hours before taking their gastric acid reducers because it really ruined their morning. And so they opted to switch to something else. And that led to the second reason, adherence. So better adherence for this patient population is going to be wildly important. Because this is a slow-growing disease, these medications can really stave off some future progressions into more harmful lymphomas. And so adherence is going to be a dominant reason why patients switch. I know myself, I can't take a multivitamin once a day. So we have options here in CLL with the covalent BTKIs, where you can have once a day dosing, or some other ones have twice a day, and then some have both. So it's really up to whatever works well for the patient. The third reason is payer and formulary changing reasons. We know for many reasons patients come in and out of insurances, or the formulary may change in the middle of the year for whatever reason. It's important here that these payer changes or differences in payer preferences are clinically supported by phase 3 head-to-head trials. There have been some that compared CBTKIs against another one and showed at least similar outcomes with possibly better toxicity profiles. And so they decided which one is probably better for themselves in their formulary. But within all of this, if there is a preference, it's important to note that those studies are based on monotherapy, so that drug by itself. We're seeing more and more data nowadays combining this with other agents. And in these instances, the data is more nuanced on if you can do that switch, because the data is still very early for some of these other agents. And we just want them to read out a little bit more before we do that.
Timmy, you hit on so many great, I think, reasons why switching occurs. And I think you gave a great background. And one area that I'd like to dig into a little bit deeper is around the formulary, financial stewardship, cost management. How should practices and payers balance that financial stewardship with that clinical autonomy when evaluating switching decisions? And should there be any guardrails in place that don't take away from that provider decision, but also still allow for cost stewardship?
Absolutely. At the end of the day, these are still oncology patients. Yes, they have a slower growing disease. Many of them live really long, full lives, but there are risks to when switching. And we have to make sure that if a patient is already established on a drug, they're doing very well, they're their whole life is around taking this medication because that's what's keeping them alive, that we do all that we can to get them covered, get them access to that medication. I understand that there are times where there are better benefits to one than another. And that is more of a discussion that our providers should have with the patient for more medical reasons or for these non-medical reasons, just to ensure that the patient can keep adherence on their medication. From the payer standpoint, I can see why there would be prior authorizations, just to make sure that the utilization is correct. We do see sometimes that providers can combine different modalities in CLL, and these may not be supported by full phase 3 trials. So I get that we want to question more about how they're using the entire therapy, which I think is appropriate, just to ensure that combination of medications they're giving them are both safe and effective.
You bring up a really good point because I know even some payers, as we're managing plans or switching formularies, there's a temptation to say, hey, we've got a difference of price here. There might be an Inflation Reduction Act, BTK inhibitor, or other therapies. Let's just switch everyone. Or they can opt for grandfathering patients, right? So letting patients continue on treatment. And I know that there's always a risk benefit there, whether it be financial or clinical. But I think one of the main things that you've said is we've got to do what's right for the member or the patient and help guide some of those decisions and not be so hard and fast based on pricing alone to make sure that patient continues therapy, I think, for that long duration. And when I think about long duration, Timmy, I also think about clinical concerns that can come up. And so if you would, you've kind of hinted at these, right? But when we're thinking about motivations for non-medical switching, we think about finances, cost management, administrative ease, but sometimes clinical concerns should be at the forefront, but not always are. So if you would, tell me a little bit about what some clinical concerns may be around switching and disrupting maybe an effective therapy.
Absolutely. The interesting thing about this class of medications is that while they all share very common types of side effects, they can happen at different incidences. That goes back to how these medications work at the molecular level, how well they bind to certain things, and so forth. They do still hit certain receptors altogether, but that attraction is less for one over another. So, for example, you may see more neutropenia in one than another, and the patient may not feel anything at all because it's just a number, versus in another medication, you may have cardiac toxicities that can be a risk for death, right? So having those very patient-specific factors weigh into what is the right treatment will be the key for the patient. And we can't see a lot of these things in charts sometimes. It's just a discussion that the provider is having with the patient. The physician may forget to add that in their notes, but it's not invalid that the physician has taken those factors into account when deciding what is the best for the patient. When we're switching to, you may have entirely new side effects. So you're almost trading one side effect for another. And that typically happens within the first couple months. So that first switch is probably when we need to be most careful that we may have patients going back to the original medication.
You really highlighted, I think, the different side effect profiles of these medications, maybe some of the, I would say, affinity of the drug binding. And I think that's so important, right? Because we have to have careful assessments for therapies. So when you're thinking about medication classes like BTK inhibitors or BCL2 inhibitors, what are the key guardrails or assessments that need to be done when we're considering any transitions in real world practice?
Yeah, because CLL patients live a very long time, it's really hard to base anything just on overall survival if you're looking at the clinical trials. These patients, again, can live just very normal life as long as the medication is working for them. And so when we're thinking about labs to look at, we're primarily looking at the beginning when they're starting that therapy, like I mentioned before. So platelets are a big one. Some of them can cause petechiae and bruises. Some of them, again, can cause those neutropenia. However, they may not cause infection. It's just that number is low, and we just have to be careful that it's not masking a progression of disease because some of these can be misinterpreted. Otherwise, we're really looking at how the patient is feeling overall. Some of them can have non-lab descript things like fatigue, diarrhea, etc. Checking in often is going to be important on the provider side. On the payer side, I think it's just important to understand that these things are happening. We're trusting that our physician and patient are talking to each other and that we just continue to support them the best we can by making sure they're used appropriately and that we're, again, allowing them to go back to whatever they were on if it does not work.
One of the questions I have is, do you think there's evidence gaps that don't support switching or support switching in these classes? What meaningful gaps do we still need to solve for if more aggressive switching were to occur?
Yes, this happens a lot in real world practice where folks are moving in and out of insurances and one is preferred over another and they're going to have to switch. There have also been published evidence where we had switching occur from one to another and looked at some of these long-term effects and saw no differences. But these are not phase 3 trials, right? We don't have anything like that available. And I'm not sure we're going to have any phase 3 trials that show any of this, but it is more important that we empower folks to publish their experiences so that we can see, like, how is everyone doing overall? And are we more confident in making sure that these CTPKIs can be used one after another for non-medical reasons to switch them?
I really like what you've said because you've kept the member and the patient in the focus. You've created good guardrails where the gaps exist. And I think the one next piece that I want to highlight is really the patient voice, right? One of the things that we really thrive on, and I think organizationally we drive forward, is shared decision-making. We recognize there's cost stewardship, there's clinical efficacy, but how do we incorporate the patient in the decision? And so if you would, maybe can you highlight the value of how we incorporate the patient voice into the treatment development and decision-making process so that we can promote good adherence and overall buy-in to the care plan?
Yes. So I think it's a mind shift in thinking that patients need to revolve their life around oncology agents, which is typically the case when you have very deadly diseases, right? Patients are willing to give up their time to go in to get to the infusion room, disrupt their day, go get their infusion, go get labs, etc. In CLL, we have to think about medications being revolved around the patient's life, which is a very different mindset. So here, the patient should be able to choose which ones that will work best for how they want to live, because we have so many options and all of these options work very well tolerated in general. And in many ways, we just have to be careful of those side effects that can be a hindrance on whether or not they can sustain a habit of taking their medications long term. Again, things I talked about before, the worst things that can happen is a patient being changed or started on something new that they're not educated well on, they don't believe in, and they just stop taking their medication because of a misunderstood side effect or a misunderstood plan in their therapy. The other thing that can be a big problem too is any access delays. So if a patient is experiencing any access delays and they're not voicing that to their provider, or maybe they just don't know to voice that, this can cause a lot of inadherence and then again, forming just bad habits of not taking their medication.
Yeah, it's a really fine balance to your point of making sure patients are feeling heard rather than just managed in these scenarios. And so payers and providers, how do we incorporate some of these patient-reported outcomes or patient experiences into these decisions when we think about the side effect profile and really the outcomes that we're working towards?
Yeah, a lot of the studies right now that are done, even real world evidence ones, have multiple years of experience. So I think it's important that because CLL is a chronic disease, it's in the name, that we base our decisions on evidence that are multi-year. If we can, 3, 4, 5 years, because that's where we're going to see how our patients do. Again, they live very long lives. Otherwise, talk to each other more. I think this experience, again, is not well published. So we have to discuss as providers, as patients, how we're feeling about switching. Most providers that I have personally spoken to believe that all of them work just the same, that there are only really a small fraction of patients that really need one or the other. And most of the time, those are for clinical situations. But again, it's really important to engage the provider KOLs, but also if you do engage in patient advocacy groups, hear what they're saying too. They talk to each other. Something that CLL patients may not go through most of the time are survivorship clinics because they don't have such a large trauma that other more acute oncology diseases go through. And so because they're not part of these survivorship clinics, their voice can easily be lost. So you have to kind of seek them out more than have them come to you.
As part of this process, we really need to keep incorporating the patient. And you've talked about so many different ways for us to do that. But we also recognize sometimes a provider or a payer may need to make a switch, a non-medical switch, either to steward best cost or to move towards a pathway compendia agent. And while we don't always want to do that, it will occur. And so I guess my question to you is, what does meaningful shared decision-making look like when that non-medical switch is being considered and it does have to move forward? Where have you seen communication break down in that process when someone is trying to move forward with a switch like this?
Yes. So if that is going to happen, I think it's important to let folks know early. I would say if you can, and most may not know, like 6 months before you're planning to make that change, because sometimes these patients only see their providers once a year. I mean, they've been on therapy for a very long time. They don't need the every month talk with their providers. And if the provider has a really large panel with multiple payers and you're only one of the payers, they're not going to know either. So a lot of the information needs to happen as soon as possible so that patients can reach out to the providers or the provider can reach out to the patient. Or if you have a really great program in your organization as a payer, have those people reach out as well. All this touch point is going to be important because if a patient, they're just going to go into the pharmacy 1 month and then get a denial because it was switched, they're going to go through thinking, oh, do I just not have insurance anymore? What's happening? So again, that bridge is going to be important to just make sure that all the teams are playing together. It's not that the switching is terrible if you do that. It's, again, all the misconceptions and the lack of education and the lack of communication of why this is being done, or that this therapy is just as effective as another as the provider can counsel the patient on.
Sounds like there's so much opportunity for us, not just to think about the provider abrasion, but the member abrasion. And how do we get that patient family advisor, get their input early on and communicate the reasons why some patients may want to stay on therapy, right? So it's not a broad sweep, but that we can incorporate more of those patient specifics. Because like you said, I think the longer the patient is engaged in their care, the better the outcome. I think that's what we're all working towards, whether you're the payer, the provider, and obviously the patient. And I think that leads to best outcomes.
Yes, absolutely. It's all about adherence at the end of the day. I have mentioned this multiple times. So I hope this is a key word in your head when you think about CLL, but also a lot of copay assistances. They don't change on a dime. They have to be re-enrolled. They have to show all these paperwork sometimes. If they're grant funded, there's all these other things they have to do too. So there's just a lot more administrative work for a medication that, again, that patient needs every day.
We talk about keeping the patient on therapy. And to me, I've seen data in my pharmacoeconomic background that shows that the longer the patient's on a successful frontline therapy, you actually reduce subsequent costs because the quicker they progress, the more their disease will progress likely, the more the cost of care will go up, whether it be medical or in pharmacy together. And so really ensuring appropriate compliance management seems to be key, almost just as much as selecting that right therapy up front. So my question to you is when we think about BTK inhibitors, BCL2s, and so many therapies used in this space, the utilization of dose modification strategies is really important. And the way I think of it is just having a strategy in play, having a policy that allows for it, but engaging that patient early. When you're starting this therapy, here's medications that you can utilize. Here's some frequent side effects that could occur. And here's the tools to mitigate them so that you're setting them up for success. I've seen that be helpful, but I was curious in your experience, both in the payer lens and provider lenses, how the utilization of dose modification strategy manage the AEs more effectively, but really avoid that premature clinical switching that we get worried about.
There was so much to what you said that is, I think we need to unpack too, because if a patient is not doing well and they're progressing, the later line therapies are quite pricey. And if we can keep patients on their first line therapy, especially with BTK inhibitors, there's great data coming forth that maybe we can eventually stop them and monitor them using a blood-based test like MRD. With what you said, it's important to make sure that patients get the dose that is right for them so that they can remain on this treatment without having to switch all the time for any medical reasons. We all know like adverse events happen all the time. When that happens, you just have to follow the package insert because that's what's studied in the clinical trials. We have to maintain that great adherence. And I think some folks may opt to switch rather than use that dose reduction. When we switch to a full dose, we're taking a risk of trading one side effect for another. And in the same vein, I've also seen patients have that side effect persist even after switching to another therapy. So if one doesn't want to switch, then lowering the dose has proven no differences on long-term outcomes. In fact, there have been phenomenal studies by international KOLs that looked at full dose patients versus those that had reduced dose, even from the onset of therapy because they were more frail or what have you. And that resulted no differences in overall survival and progression-free survival. And this is because many of these medications work so well that even in lower doses, you can fully occupy that receptor. You can fully saturate it and inhibit it. And so we know that there's another path for these patients. If they're having side effects, you can manage them early, give them any supportive care, but don't be afraid of going lower on the dose rather than switching.
You've really brought up, I think, some really key considerations that hopefully people are listening to. One of the number ones is leveraging supportive care, leveraging dose reductions. Also, these medications really provide best-in-class efficacy, and they can really be helpful in this patient's journey. One of my questions, too, from a health plan or even system perspective, is how can we develop better policies, whether it be EMR or medical policy, to support this kind of dose optimization, whether then default to switching or abandonment to another therapy? Is there anything we can do to more hardwire this as we kind of create this best practice so patients can stay on the right agent for them longer, and that we're making the tweaks earlier instead of more reactive?
I'm going to go from non-health system first. So education, right? A lot of these providers that are managing CLL may not be an academic hematologist because CLL is so prevalent that there's a lot of community providers out there. They're not just focused on hematology either. So some of this data they may not even see because they're focused on a broad array of oncologic diseases. So being able to educate those physicians broadly is going to be important. Within the EMR system, you can, if you're using, let's say, Epic, you can utilize the beacon treatment protocols and have education posted in there too. You can also have different types of pop-ups. So when a patient is going through this therapy, you can have, hey, these are things, educational points that you should just be aware of. This can either happen just once. I know alert fatigue is a big thing. So it can happen just once, or if that really is a problem for your institution and you're truly trying to address it on that provider level, you can have that pop up every single time. Another thing you can also leverage is keeping in touch with the pharmacy. If you have an integrated system with a good pharmacy team, they can tell you what's going on with the patient. They can pull that data for you. And as a payer, you can pull that data for your clients as well. Let them know what you're seeing. Give that feedback back to the health system so that providers can just be more aware of their prescribing habits.
You've shared so many great takeaways today. And just to review, number one, recognizing that non-medical switching has implications, right, to the patient outcomes, to their adherence. We need to be really thoughtful. We need to engage that patient, not only looking at the cost effectiveness, but also the clinical impact of making a non-medical switch. And I think furthermore, how do we incorporate that patient's voice into the decision-making process so that their shared decision-making becomes key to all that we're doing? And lastly, if we're going to make changes, let's do it in a thoughtful manner that makes sure that we're creating a good context. So Timmy, in summary, we've had a lot of great discussions, but if you could leave maybe one practical change that organizations, whether it be a health plan or health system, could implement tomorrow to better balance their framework around non-medical switching, what would it look like?
It would be to promote that this is truly going to be a shared decision-making opportunity, that the patient, the providers, even if you want to switch, give them the liberty of time to decide when to do that switch, because we don't want to do that when the patient does not have disease control. When they have disease control, there's a lot more levers they can pull and also come together and meet your goals as well as a payer. That liberty of time is going to be so important. And I think everyone is trying to work towards the same goals. It's just, again, making sure that we're doing this in a very, very thoughtful way, as you mentioned, Ryan.
Thank you, Timmy, for a great and informative discussion. And thank you for listening to this episode of Unscripted, the AMCP podcast. This episode was sponsored by AbbVie. For more information about AbbVie, go to abbvie.com.